Stanford. Let me get his talk set up.
All right, I'm Dr. Jerald Simmons, and I want to present to you about treating patients that do not meet the criteria of desaturation for the diagnosis of obstructive sleep apnea. I really want to thank my whole team, but primarily one of my nurse practitioners, Sharon Barlett, who helped significantly the data extraction for the study. And I have no conflicts of interest to disclose regarding this study. So what's the problem? The problem is that when you suspect the patient has obstructive respirations during sleep, what's the threshold that you want to utilize to tabulate your respiratory events so that you can obtain data that's going to justify your treatment? You've got a symptomatic patient, you need data, so where's your threshold? Well, there's a lot of controversy on the definition of hypopnea. And there's many different methods that have been implemented, and it seems that nowadays a lot of insurance companies and Medicare seem to want to gravitate towards patients needing to meet the 4% desaturation rule in order to calculate hypopneas, and this actually leaves a lot of patients untreated. There's publications that have addressed this controversy. Ruland in Journal Sleep in 2009 had a good description about using the different methodologies, the recommended ASM criteria versus the alternate versus the Chicago criteria. This study was good. It talked about how the AHI will vary quite tremendously using these different methods, but it didn't look at outcome and what would happen if you treated these patients based on the different methodologies. The American Academy of Sleep Medicine propagates the problem because they are requiring a 4% desaturation in their criteria for the interscore reliability program that our technologists are using for the quality assurance assessment. So we're basically propagating this concept that you have to have a 4% desaturation. This is what the technicians are being assessed when they're doing their interscore reliability assessment, and therefore a lot of the studies and a lot of labs are going on to tabulate only those events in which there's a 4% desaturation. There's very few studies that have been done that look at outcome based on treating those patients that don't meet that criteria, and that's the objective of our study, is to assess what is the outcome when you treat patients that do not meet that criteria. Now, this is just from the handbook from the Academy showing what is recommended. It's going to be greater than a 4% or greater desaturation with a decrease of approximately 30% or more of the airflow. Then the alternate is saying, well, you need a 3% or higher desaturation, but you have to have a much greater degree of decrement in your airflow signal. All right, so for our study, well, first you need to know in our lab, we tabulate hypopneas independent of desaturation. We're looking at decrease in airflow leading to arousal. But we went back and we retrospectively pulled charts and looked at those patients that have apnea-hypopnea indexes that when we utilized it, we went back and looked at the desaturations, and if we used desaturation, if they had an apnea-hypopnea index of less than 5, and we call that the AHI, and we used a 3% desaturation, and then our typical definition would be that, which for the purposes of the study, we call the non-OX AHI. So it's decreases of airflow leading to arousal independent of oxygen changes. So the non-OX AHI had to be higher than 5, but the OX AHI had to be less than 5. All right, so we retrospectively reviewed charts, and we were looking for patients that had been at least 6 months or longer since we made our assessment and intervention. So we weren't looking at outcome for just a few weeks. We wanted to see 6 months or longer, right? And so basically, we were looking at a group of patients that would have gone untreated based on the criteria that the AASM is utilizing for identification of patients with obstructive sleep apnea. Then we did follow up for those patients that qualified, again, for 6 months or longer, and we look at the Epworth Sleepiness Scale and the Patient Global Impression scales. We're looking for change. We also look at body weights to see if they had changed also, because we knew that there was a long time interval for some of these patients. Maybe some patients lost weight. Okay, so this is not a study about RARAs. We're not talking about respiratory effort-related arousals. All right, we're looking about patients that have an appreciable, approximately 30% or greater decrease in airflow as measured by either nasal pressure, cannula, or Thermistor thermocouple, greater than 10 seconds, leading to an arousal in EEG or EMG. So let me show you some examples. Pictures speak more than 1,000 words. Okay, so here's a patient, the saturation was between 92 to 94%, and here's a decrease in airflow, and with two methods of looking at flow, and here's the arousal. So we would call that a hypopnea, but there's no significant desaturation. Here's another event, reduction of airflow, again, you can see the significant increase with the arousal, and you can compare to the larger values here, there's a significant decrease leading to the arousal. Okay, this is a 2-minute screen, the others were 1-minute screens. Here's a decrease in airflow leading to the arousal. See the Bruxing event right here. So we actually tabulate EMG quite extensively. Okay, now this is a more complicated case. This is a patient with a lot of periodic leg movements asleep. All right, their oxygen is going between 94 to 96%, and the periodic leg movements are causing arousals, causing disruption of sleep. But here you can see evidence of obstruction. There's snoring, and there's decreased airflow. So we would call that hypopnea. But there's no desaturation that would meet the criteria based on the standard approach recommended by Canada. So these events should not be considered RARAs. Why? Because there's an appreciable decrease in airflow, and they last at least 10 seconds. And when you look at RARAs, there's a lot of vaguety there of how you calculate a RARA. But a RARA, if you're going to see a decrease in airflow, it may be an event that's less than 10 seconds. I mean, what's the dogma about 10 seconds? Why does something have to be 10 seconds to be significant? And that's like saying, well, if your event's only 8 seconds and it causes disruption of sleep, well, then it's not significant clinically. I mean, that's a little bit absurd. I mean, these were, certain guidelines that were put forth that allowed us the ability to tabulate the fragmentation of sleep. But as we've learned more and gained more clinical experience, we realize that there's shades of gray, and sometimes we need to go outside the exact boundaries. Some people like to stick exactly to certain 10-second rules and what have you, or 30% decrease in airflow of a qualitative value, which is not really quantitative. So anyhow, if you're going to talk about RARAs, this is the kind, and this is not part of this study. This will be another study, another date. This would be a RARA not calculated. Here's obstructive breathing. Here you can see a PES, increased respiratory effort. Here's the arousal. Airway opens up, and there's less respiratory effort. And if you look real closely, you can see paradoxical respirations that with the arousal resolve. And this particular RARA might have gone undetected because the snoring didn't stop. But here's the arousal. So this is not part, this kind of event is not what we tabulated for the study. It was more of the other type that are more visually obvious. You don't need esophageal pressure monitoring. You just need to exclude the oximetry aspect of the definition. So what did our results show? Well, we went back and looked at 240 charts that we identified that met the criteria of having a low ox-AHI, less than 5, and a non-ox-AHI greater than 5, that had been at least 6 months since the time that we made an intervention. Okay? 69 of these patients we couldn't reach. Sometimes, some of the follow-ups, and they were done a while back. 18 patients never started treatment that we recommended. So there's 153 patients that we successfully contacted for our assessment. 37 were not compliant with their treatment. And there were 116 that were compliant. for 6 months or more. The average age was about 51 years old, ranging from 21 to 83 years old, 35 males, 81 females. It's interesting that there's a much higher prevalence of females. Okay? Follow-up assessment ranged from anywhere from 6 months to 65 months, average of 20 months. 88 patients, which represented 76%, demonstrated improvement in their Epworth Sleepiness Scale, going from an average of 12.7 down to 8. And 101 patients of this group had improvement in their PGI scores, the patient global impression scores, which represent 87%. So we looked and did an ANOVA analysis looking at the statistical significance of our group, and we compared the changes in Epworth, PGI, and weight. Okay, and it was clearly statistically significant with a p greater than 0.01. Then we did t-tests to see where did most of our change come from. And the t-tests for the Epworth Sleepiness and the global impression scales were significant to a 0.001, where the t-test for weight was not significant. So weight didn't really play a role, and by adding it into our overall group analysis, it weakened the statistics, but it was still statistically significant. So the change was because of clinical improvement, not because of, and weight did not play a role. So what's our conclusion? Well, our results correspond with a long history of clinical experience that it is worthwhile to treat these patients that have disrupted sleep due to obstructive respiration, even if there's not desaturation associated. Unfortunately, many still cling to this dogma that you can't tabulate respiratory events unless there's the desaturation, and that treatment is unwarranted otherwise. Right? And it really confounds our industry because, you know, insurance companies are gravitating towards this, and there are people that are getting denials. And now, you know, if we're trying to justify why do we bring someone to a lab, if it's all about oximetry, just put them on oximeter and send them home. And, you know, there's a thrust for that to happen. So if you're going to justify why you have a sleep lab, you've got to look at the data closely and identify these more subtle events that may get missed by automated assessments that are just looking at oximetry changes. So we encourage that those labs that are not, those labs that are strictly adhering to the 4% desaturation, consider looking at extending their diagnosis to include these other patients. Clearly, more studies need to be done in order to increase the momentum to change what our criteria is in the field, and so that we can hopefully get away from relying on oximetry in order to establish a diagnosis. And it's not to say that oximetry is not important. It's very important, and it does make a statement about the severity of the pathology. But when you have symptomatic patients that need treatment, why create a scenario that withholds them from getting coverage for their treatment because they didn't desaturate? So anyhow, for those interested in participating in a multi-center prospective study, contact me. My email address, go to my webpage and contact me. I'm trying to get a multi-center study. I really want to change our methodology so that we can treat more patients without having to dance around the insurance provision. And yeah, that concludes my talk. Thank you.
Thank you. That was great, Dr. Simmons. Are there questions? I think I see one in the back.
I think that the desaturations are not so important, but inner score reliability is probably better if we use a 50% fall in airflow. And I think that's the problem. It'd be interesting to reanalyze that data, looking at the 50%, because I think the goal was that we score alike. And the subtle changes you show, which may be 30%, if you check your inter-score reliability, which you could introduce into this study, I think would warp your findings. So that's the problem. Might be better to look at 50% that didn't desat.
I agree with you that when you're trying to do lab-to-lab reproducibility, obviously the more subtle the phenomenon that you're trying to reproduce, the harder it is to reproduce that. But then the challenge really becomes that of training and raising the skill level of the technologist rather than lowering the criteria for establishing a diagnosis. But I understand your point. For reliability, and that's what Medicare actually was looking for. They wanted to see reproducibility. They couldn't find it. That's why I think they gravitated towards oximetry as being so important.
I think I see two more questions. Is that right? And then we'll move on. Or we'll do all three and then we'll move on. So from the back.
Thank you. That was obviously a really interesting and relevant clinical question we all have. The question I have is,
CPAP adherence or compliance with CPAP?
Yeah, like number of hours of CPAP adherence and what's their relationship with the outcome?
Well, in this study, not all of the patients that we bring back to look at that. I mean, we obviously that's important. At least I would say when we ask the patients in terms of looking at compliance, we ask them, I usually more than 4 hours or more. But we didn't bring all these patients back, some of which hadn't been in a couple of years. So we did a telephone assessment to go through questionnaire to assess.
We'll take one in the front and one in the back, and then I think we'll have to move on.
This is short. It's a great study, but have you thought how this is going to impact home sleep testing?
The other way around, I see this could impact our laboratory testing. This actually lends to try to preserve what we're doing in the laboratory, because the more we rely on oximetry for our definitions, the more we can do it in the home. I mean, oximetry is simple, but there's more to it than that. And so I think the more we implement this, and even I do a lot of esophageal pressure monitoring. That's really not what we're talking about here. But for those patients that are symptomatic and you can't diagnose them with a portable monitor, or they're on CPAP and they're still having persistent hypersomnolence, those are the ones to bring in the lab. And that's when you need to look more closely at the data to identify whether there's an obstructive respiratory event or some other phenomenon going on. So I think if we're going to preserve laboratory testing, we have to be more meticulous in how we perform it.
There's a question in the back, and then we'll also take this last one in front on the softies. So go ahead in the back.
Actually, not a question, and I apologize for that. I want to punctuate what you said. As a clinician, it's absurd that we rely solely on counts that are derived in the way that we typically do it. We know that there are a lot of patients superbly or extremely symptomatic that we're not picking up with our strict counts. And so, really, I just want to support what you're doing, and we'll be doing so, and thank you very much.
Thank you. Well, please contact me if you want to participate in the multi-guy center.
Last question in the front here.
Well, I certainly want to echo what everybody has said. I think your work is obviously extremely important. I'm also wondering whether or not you were thinking that perhaps by broadening the definition of events that we include, are we capturing arousals? Are we capturing a body of patients who, by extending the definition to include 3%, we also incidentally including people who are having more frequent arousals that we might just miss if we're lopping out anybody who's not having a complete apnea or 4% desaturation. And I think as we look going forward where our role is in terms of testing in the sleep lab and testing at home, we're really on the cusp of losing the subtle cases. And I would just encourage everybody to think about reaching out and expanding our definitions of what's important and not just lopping off 3% desaturations or by extension.
I totally agree. And, that's why, upper-airway resistance syndrome is out there. A lot of insurance companies say there's not enough outcome data to support the implementation of treatment. But I think that by extending, there's more than one way of looking at arousal too. Heart rate variability, pulse transit time. People say there's non-cortical arousals. The way we've looked at EEG is also very crude. Only recently have we added frontal EEG, but that's where the most sensitive region is for identifying arousal. And there's other methods of computation of EEG that will provide more data. But really, even when you look back at the stroke study, for example, oximetry, maybe a lot of these patients, in my mind, a lot of these patients probably don't hold a high cardiovascular risk. But I call them hypopneas because I need to get them treatment and I see all that. But I think those that do desaturate probably have more cardiovascular risk. And those that don't still can have daytime symptoms, still are symptomatic, still fall asleep behind the wheel, et cetera, et cetera, et cetera, still need treatment. But we've been not as proper in identifying and pushing the payers to support implementing treatment. And so we lobby them all into hypopneas. Maybe we have to talk about different kinds of hypopneas for our clinical understanding purposes, but not to result in a scenario that's going to prevent treatment from being implemented in someone that doesn't desaturate. So we need to do it officially.
Thank you so much.
Thank you.
Thank you, Dr. Simmons. We're going to move on to our next talk.